we need to be mindful of so that when I'm going through and doing my environmental scan, I don't get caught up in all the delicious data and leave your concerns and the things that you need us to cover off the table. Is there something that we should be mindful of that we can just put a bookmark in and make sure we come back and address? Anybody got any news, something fun, something exciting? Okay. Well, then without further ado, let's just go ahead and get this party started. I'm going to bump up the resolution a little bit on this because, only someone with a pointy head like me could possibly appreciate the scope and the breadth of this particular environmental scan. So I hope that you guys can see it. When I do bump it up, it wreaks a little havoc with my formatting, but that's okay. We'll just keep on keeping on. Is everybody at least able to see this, or are you able to bump it up on your own monitor, or do I need to give it one more notch? Thank you. Guys are quiet today. Everybody's in a post-election day haze. So, all right. So I'm gonna kind of pick up and show you guys where we are. Um, one of the things that I have found is helpful is when we sort of look at where we've been, because that really informs where we're going. Our implementation guide, while we have divided the content into specific buckets, the implementation guide is a single tool, and our focus for STU1 was the person author documents. And so we built a lot of structures, and we came up with very distinct ways of informing one machine from another machine as to what's coming over. One of the changes that we made when we pivoted from person authored concepts and how do we reflect these and how do we enable machines to talk to machines, when we pivoted from person authored to practitioner authored, we really came to a realization that while we're all working on how machines talk to machines and how do we get these paper documents that are not always available when we want them to be, that don't move well from one system to another system, when we're trying to liberate ourselves from the world of paper and move to a more modernized digital availability of information, we knew that we've also and got to make sure that a human readable version of the form is also made available. So there's a duality in the work that we do. Yes, we are dealing with discrete concepts. How do we ensure that what we have recorded in one machine is accurately communicated with a receiving system? But we also have to have a second layer, and maybe that's the first layer. The first layer is the people. All of the good people who have their EHRs, who have their personal health records, who are looking at all of the information that's out there. And how do we make sure that they can see what they need to see? So a human readable version of the form also accompanies the metadata that machines use to talk to machines. In today's world, if you have moved a little bit away from paper, chances are good you've got a scanned document. And that's fine. There's an appetite out there for the treating clinicians or the individuals or their caregivers to take a look at a scanned document and go, hey, this is legit. I can see the signature. I know what's out there. This is no different than holding a piece of paper in my hand. So that's, I think, what we have to be cognizant of when we're looking at the work that we do. Absolutely, we've got to move an image, a PDF, if you will, although PDF is kind of a limiting thing. But, I've taken a piece of paper, I've scanned it, I've housed it in an EMR, or I've housed it in my personal health record, or I've uploaded it to my patient portal. And that's what I see, and that's what I know. What we're building for also is for machines
So
to
you
be
made
able
me
to
say to
say,
go and make macaroni and cheese. You said,
hello,
right?
Juby. Juby, you might need to go on mute.
You heard him.
You want to make it? Have Alexa.
No, Juby,
I cannot chew food. Sorry.
there we go. Go ahead and mute her. So we also want to make sure that we are prepared for tomorrow. And when tomorrow comes, that those machines can pick up this information and actually fire off clinical decision support. So all that being said, here's where we started. Okay. Oh, that's right. We need a section in the metadata. This is aside from the human readable form. We need a section that talks about healthcare agent, treatment interventions, care experience preferences. What happens should I pass away? What other documentation is important? How about witnesses and notaries? How about administrative information? And we modeled that when we looked at practitioner authored portable medical orders. And that's your DNRs, that's your pulse, that's your MOLST, your TPOP. How do we take that same structure? Because we're not building a new IG, we're adding to our existing IG. So, okay, when it's practitioner authored, so I need a medical order section. I need a completion section. I need an administrative section. We were looking through our massive environmental scan. And don't you know, there's a couple of portable medical order forms that actually solicit with the practitioner's signature how the individual feels about organ donation. So we took what we've already done, right? We already had a goals, preferences, and priorities upon death. We had an organ donation observation, and we said, oh, well, I know how to do that. So we'll go grab what we did before because it's still there. And we'll make sure that if an implementer says, hey, I want to digitally capture these portable medical orders. And okay, so we already know how to do this piece. Let's pull this piece over. There's no new work. We know how to do it. We're just going to bring it forward when we're talking about this kind of document. We know that there's an additional documentation section, and maybe for portable medical orders, what goes in here is a little different, but not hugely different. And believe it or not, there are practitioner authored documents that for that jurisdiction, they're like, hey, okay, I want a witness, or in my jurisdiction, I require a notary. Well, we know how to do that. So we could bring that over as well. And then we learned that there are a few documents that, with a practitioner's signature, and maybe the intent in that jurisdiction is to get some teeth in that designation because people feel differently about advanced directives than they do about portable medical orders, than they do about all different ways of expressing these kinds of concepts. And so, guess what? We know how to reflect these designations. We did it before. So, this thing's getting a little murky and I'm going to need to reinvent it and clean it up just a little bit. But, my goal is to say, guess what? There is more commonality in these documents than a guy might think at first pass. And that's good news. And then, of course, we have mental health advanced directives. And boy, howdy, is there a lot of commonality in the structure, the shell of how these are communicated, even though there might be differences in the specific concepts that are shared. So we're starting to see these patterns emerge. And when these patterns emerge, it's really important as we notice things through the scan that we kind of go over the color document. Guess what, you guys? We're going to have to go grab the healthcare agent section that we already fine-tuned in the first version of this guide. And we're going to make sure that it is an option when you're talking about practitioner authored orders. It's an option if in your jurisdiction your form has this thing. So you will see kind of how this has all come together. We went over this a little bit last time, but I wanted to solicit from this group of well-seasoned professionals, informaticists, physicians, all of you who are just so incredibly wise in these topics. I wanted to ask you guys a little bit of a question. Now, I'm going to take you back here because this is really, really important on practitioner authored documents. So we know in the medical orders section, it is the guts. It is a CPR order. It may contain initial treatment orders. It may contain additional orders or instructions. And the different forms might have, do you want to be hospitalized? Do you want to be intubated? Do you want ventilation? Do you want non-invasive ventilation? In a particular state or jurisdiction, they may ask on the portable medical order, how does the individual feel about dialysis? What are their thoughts on antibiotics, blood transfusion? How do they feel about medically assisted or artificial nutrition? And then how do they feel about medically assisted or artificial hydration? So we know that's like the guts of why we even do portable medical orders. And then we know that there's a completion information. And this may be the second most important thing to the human. And remember, you've also got a human readable version of the form. So this is an and. But we tried to group these things logically. What makes these orders actionable, okay, to a machine? So a machine might be set up to go, hey, when you get a thing, go check for a signature. And in this jurisdiction, make sure that the signature associated with the provider has a role equal to MD, DO, NP, PA. You can kind of see how data helps inform machines where humans don't have to take that additional step. So the completion information is super important. What is it that is the most important thing after the order that I need to know so that I can honor what is being shared with me? Administrative information is also important. Maybe it's the second most important thing. Maybe it's the first most important thing. But regardless of the order, there is a bucket of concepts that are not trifle. Just because it's called administrative doesn't mean it's not critically important. What state was this form completed in? I may be on the Upper East Coast where I can drive 45 minutes and hit 4 different states. And so I may be in a state where I honor this state, this state, this state, and this state. And so it is important for the system to know because logic may be built in saying in this particular state, I can also honor these state portable medical orders, right? I may have the photo. I may have all different kinds of things. So there is a concept that we sort of talked about last week about the patient goals of care, and that can be represented using the goal resource as a personal health goal. So, okay, I know it's a little murky, you guys, but I'm going to get us there. Maybe the statement of the document creator that came off of the form. Now, is that, critically important to the completion information? Maybe, maybe not. We're going to put it in administrative because it is important. Who participated in that discussion? That's important. If the form collects it and I am the attending who's building this particular portable medical order, I really may need to know who their PCP is and how can I call them and say, hey, dude, I've got your individual here in my ICU, and so I needed to call you and see what I need to know to provide good care and treatment. Hospice or palliative care enrollment indicators, that definitely affects treatment. Emergency contact, general form instructions. So I go over these 2 sections because I would like to solicit from you guys a particular concept. There is a particular form that we deconstructed in our environmental scan that deals with a statement of capacity. And I think in many, many forms, capacity may not be visible on that form. So if the individual does not have capacity, cannot, speak, and that's not necessarily a mental state, it might be a physical state, right? I've been so severely injured, I can't even talk to you and negotiate this form, but I do have a surrogate who's going to come in and speak on my behalf so we can construct a practitioner authored portable medical order. So most of the time it looks to be outside of the form and part of that medical encounter. But we've got a form that actually pulls that to the forefront. And so I was wondering from this esteemed community that if a particular form has a statement of capacity, and if it would be helpful to you guys, I can bring up the form. I never know what kind of information to pull forward in order to have a discussion. But would you guys believe that whether or not an individual has capacity on their portable medical order, that jurisdiction actually has a statement signed by the practitioner as to whether the individual does or does not have capacity? Is that critically important as a piece of completion information, or is that more totally important, but I believe that it's more administrative information that I need to know? I just wanted to solicit some feedback from this community. And if you need more, show me more, give me the form. I can't make a decision because I need to know more. Please identify that, because it's really important to hear what all of you have to say. I'm going to go on mute. Somebody better say something.
Something.
Raj, what do you think? You are an extremely well-respected clinical professional, in this space. What do you have a dog in this fight? Do you have a stance you would care to share with us? Raj is my go-to.
No, I just want to applaud everything you're putting in. It's just as we have seen, we know what we know and we don't know what we don't know. It is very complicated. I look at the screen and I
Your
think to
head
myself,
explodes.
yeah, and that, yeah, it's, it's, I think it's all in the right direction. So I think some of it, and I just, and that's just is the magnitude of things that are already existing in different shape and form. How do we bring all the data sources that have this information in some shape form? That is kind of the norm now, which I think you've been speaking throughout, and just, yeah. So I think that, yeah, it's just, I just say this is all steps in the right direction. I still can't, kind of arms around it. I will keep listening, and I'll let you keep, just chipping away, like one strike at a time. That's all I'll say. I mean, I see where you're going. I am here for you, but I am I'm cautiously optimistic that we can get where you're trying to go.
Yeah, and I think we're making, great strides. And gosh, if you guys, I mean, it's okay to say, I don't freaking know. I don't know. I don't know where you're going to put it. I care differently It's not that I don't care. Of course I care. I care differently where you put it. Yep, it's an important issue and I don't have a clue. Y'all do what you do and chances are good I'm not going to have a problem with it. I mean, that's fine too, but I can't I don't think we can move forward without you guys at least saying, huh, will you look at that?
Yeah. No, I think the words of encouragement is that as as um, as chaotic as this is, I do think that if you just look at the natural progression of this work since we decided to do it, and you were the new member to PASIO group, right? While we were working on the first two projects, and then and then picked this 2 years into our work as overall post-acute interoperability, and you were the new person in the field that we wanted to look at, and then you come in, and then if you look at the last year and a half, 2 years that we've been talking about it, it was just us wanting to do this, and exactly what you have on your slide today was kind of just what we thought was going on. But now you actually have it in a slide with references and with the sources. And also, I think one of the frustrating part initially was that there were players, right? So there were people. See, my only dog in the fight is my patient, right? And so, but the problem is, and that's just not how it works. The way our health information technology architecture is, there are a lot of dogs that are big dogs, right? And they have this addressed according to how they want. And then comes the issue that their versions and their methods, and there are people who've gone down like with big investments in how they hold this information or how they do end of life care within their environment, which is blocked off from other people. And so I think over the period of last year and a half, we had some big people who have dedicated work in this field kind of join us and at least have a discussion how open they will be to open, and have a collective. But I think just getting the kitchen sink ready is very important, and I think we're getting there, right? And then we can start, with some of the concepts that you have, and that's where obviously people who are dedicated to the work, including your company, and a few groups that have joined us recently, right? And I think, how do we align the public, private, and for-profit, nonprofit people who have, um, whether you say dog in the fight or skin in the game, to kind of, come together and see that my dog is also important, which is the patient.
I love that. Thank you, Raj. I agree. And maybe sometimes we noodle over these, and I see you, Abby. I see you, Britt. I'll get you in just a sec. I think sometimes we worry about doing the very best job we can do, and your observations are critically important. Maybe it matters more that we just do something than agonize over every single detail. And I thank you for continuing to stay with us. Abby and Britt, I don't know who raised their hand first, so I'm going to go in alphabetic order because I'm a simple girl. Abby, would you care to weigh in? I brought the form up, you guys, just so you can see where it's coming from.
Yeah. Okay. Thanks. So for this component, and if you're thinking about like a portable medical order, a post-portable medical order, the section where on the national form release it says discussed with has an indication for capacity. So I'm just coming at a point of like, do we need to reinvent the wheel? But if we want to use the post as an example, as a kind of evidence. The portion that says, does the patient have capacity, or discussed with patient has capacity, is on the back of the page and optional. So in terms of your question on whether it should be mandatory administrative, I would say more administrative, mostly because you don't want to have too many barriers to completion. But I do think it's helpful information to have, and it can protect the provider.
I love that perspective. Thank you. That was really insightful. I'm so grateful for you guys. Brittany, please go ahead and share what you're thinking.
Yeah, thank you, Abby. That was super helpful context. I think my question was just, I thought initially Maria was asking whether it should be contained in the administrative information section or a different section. And I couldn't remember what the second section you had suggested was.
I'm sorry, I'm fiddling around trying to help, and I'm not helping. Yes, there's a completion information and then an administrative information.
Okay, gotcha.
Yeah.
Thank you.
And I think what Abby just shared is we put the participants in the administrative. Again, it's important data. Just because it's in something called administrative doesn't mean it's, inconsequential. It is important data. And I think what Abby was saying is, it is a related, intertwined concept. Whoever participates probably is tied to capacity. So you guys probably should put capacity close to where you're reflecting the participants, because you can't separate the two. If I was listening with at least a part of my brain, I believe that's what Abby recommended. And Brittany, are you kind of thinking the same thing, that what she said is
Yeah.
Yeah, okay, good. All right, cool. Thank you for that. I'm sorry it took me a minute to get there, but see, look at the admin area where we shared, discussed with, and that's Maria speak for don't be silly, this is where this belongs. So I appreciate that very much. But you've still got your hand up. Did I cut you off, or?
Ooh, no, let me lower that. Thank you.
No, you're fine. Okay, thanks, Abs. Okay, so a lot of this other stuff we know. Let me see. Okay, I had two forms that dealt with the organ donation, so we know how to do that. We know how to reflect that. Let me see, administrative. Again, I had the capacity discussion all over. Oh, look at me. I actually put it near the participants. So while it's in like 4 different places, I was wondering if that's where we need to be. Okay, good. I have a specific, there's the capacity statement again. I had a specific question I wanted to ask you guys. I'm in the administrative area. Quit scrolling. I need to get down. This is kind of a critical question for me, for all of us, but since I'm on the call. So I have a question, you guys, on all of these portable medical orders. Most of them have a patient or surrogate signature. All of them have a practitioner signature, like, duh, it's an order. A few of the forms, many of them, have a date form prepared. Okay, great. There's the requisite signatures. Some of them may have, what date did you prepare this form, which is a different date sometimes than the date the doctor signed it or the date the person signed it. And then a few of them actually have an expiration date, and we'll come back to you guys with some technical ways that we could reflect that. But I wanted to ask this group, if you're looking for, and I'll call it an effective date, because I don't know how else to ask the question, what is the date that the form is activated? Is it the date that the practitioner signs it? And is it the date that the patient or their designee signs it? Or is it the date the form was prepared? Like if there is a gap, right? If this form is prepared and my social worker or my nurse navigator or my admissions nurse or whoever does it goes and sits down with the individual and teases out their answers and explains things and makes sure that everybody's clear on what is being reflected. And let's just say the doctor comes and they sign the form that day. And let's just say that the next day the doctor comes in and says, "What do you got for me?" "Oh, okay, I see. Yep. Let me go have a discussion with the individual, make sure I'm comfortable that the orders I'm about to sign are accurate and faithful." If there is a day that is different between one signature and the other, and gosh forbid, the date the form was prepared, let's say it took 2 sessions. Maybe I sat down and
Maria.
yeah.
Yeah, no, I mean, because there are no benefits or financial incentives that can come in with a retrospective date. So answer to this is whichever comes latest is when this is effective. So for example, if there is if there's an event that needs to be addressed that is per the content of this, and there's no doctor's signature, I don't think it will happen that particular because there will be orders associated, there'll be care associated. So I guess your answer is whatever happens last is when the form gets effective on. So it's different where you're applying for benefits.
Raj, that's actually incorrect. And I don't want to cut you off, but I want to make sure that we're following standards.
No, I get it. So I'm talking again. That's why I'm not a lawyer. I'm a clinician, and my patient, if there's not a signature and there is a physician order related matter, that will not be carried out. So if you want to argue on when it is effective, yes, whatever you say stays. But if there is a IV resuscitation or G-tube feeding or shocking, if the doctor has not signed off, it will not happen.
Well, yeah, I 100% agree with that. But what happens if the doctor signs off and then the patient doesn't sign it till the next day? That order still goes effective on the doctor's signature date. That is the end all be all. Now, that form won't be valid until all required elements are there. But we've been actually talking with my directives quite extensively in the national post community. And that what happens if, say, a form gets filled out with a nurse, the patient signs it, and then the doctor signs it, or the doctor signs it, and then the orders are changed. We need that date to be updated. So I agree, the physician signature has to be there, but that is the date. Even if a patient signs it later, it is always active on that date, even though it won't be valid until all required elements are there, if that makes sense.
So you're kind of agreeing that it's the doctor's signature that activates an order. And I realize as I say that
100%, but it's not always the last signature. If the last signature is the patient, then that's not the date. The date is based on the doctor's signature or the nurse practitioner, PA, depending on your state.
Right. So my use case was flawed. So let's reverse that, right?
So, and
Let's say,
again,
yeah,
I just want to, if so if I don't see a scenario where doctor's signature is there and patient signature is not there, um, where the doctor just signs off and there's an uncertainty whether the patient's going to sign or not, right? So it would be
Not that
not.
there's an uncertainty, but the if you're thinking of maybe a telemedicine visit or a paper form, they could happen on different dates.
Well, I understand. But a doctor will not sign it if they don't know and they are not first or second in knowledge of what they're signing off is true, right? Um, and so uh, that is, I will say that uh, whenever the doctor signs it, which in the order of things should be the last thing, right? A doctor should
yeah,
not be preemptively signing it, saying, "Oh yeah, I'm going to have a discussion," and that
No,
email.
no, no. That's
So,
not what I'm saying. That's
okay,
not what I'm saying
I just want to
either.
be clear.
100% not what I'm saying. I'm saying that we see all sorts of scenarios and that we will see a doctor who has a form say they're having a telehealth visit with a patient. And while technology can alleviate a lot of what we're talking about, it happens all the time in rural areas that a doctor is having a telehealth visit with a patient with a paper form in front of them, filling it out with the patient, signing it, and then the patient might come in later and provide their signature. Now, there are states like Oregon where the patient signature isn't needed. So that, is a different case. But if there is a way to do it, we will see it. We have seen everything. And so from the national poll standard, the date of the provider signature, the doctor or the PA or the NP signature that is on the form is the end all be all date.
yeah, and that's my fault. I should have not been so specific. I was thinking that, I can't help my LT pack days. So I'm thinking, okay, my team has done everything they need to do. I've got a practitioner who's coming in once a week to make rounds. It is logical to me in my narrow way of thinking, which you guys are you guys are there to level set me. I was thinking the doctor's signature is after the person's signature, but Abby, you're right. And I think you and Raj are actually on the same page. If it was a telehealth and the doctor was able to say, yeah, I was there. I know what they said. I'm signing the order. They just can't get it signed until tomorrow. In that scenario, certain jurisdictions may not require the person or the surrogate signature. And you're right, it's the date that the practitioner signed the order that the order is effective. And I don't care if you're talking about portable medical orders or anything, an order is an order, an order. So that was my fault in having a bad use case. I apologize for that.
No problem. We just see all sorts of Wild West things that, there's the right way to do things, and then there's the way people do things, and those aren't always the same.
Well, and keep in mind, we're still going to have a form. There's still going to be, I'll call it a PDF, although I know that's not good karma. We're still going to have a PDF that moves from one system to the other system. And honestly, a lot of clinicians are going to glance to make sure that the signatures are there. They're going to care differently about the date. But when we're building an IG based on here's how you should be doing it, I guess it's incumbent on us to get the right marching orders. So, Raj, if it was a telehealth and the doctor just literally conducted the session or the practitioner and was able to sign off on the order, but maybe the individual wasn't able to sign until the next day. In that case, it might not be the latest date. It would be the doctor's signature date. Am I correct in my statement?
Yeah, I just, again, not to beat this horse further, but I am still uh, wanting to know how does this discussion effective date is any different. I Because I think if I heard it correctly, that the effective date, if there is such thing, then if let's just say doctor didn't get to it, right, for some however reason, missed it, didn't get to it, or somehow it's just happened to me now. There's a month delay in reporting. Just one of the things that fall in the okay. All right, Abby. So I guess then we're all saying the same thing. All right, scratch that.
No,
So
and I appreciate you guys teasing this out. I'm sorry, whoever was, I'm sorry for interrupting you. I apologize. I'll type notes and be quiet.
No, I just have a kind of a higher level, like a zoomed out question of this conversation, which is I understand this workflow very well from a paper perspective, but if if there's a signature in place and it's active because a physician has signed it, or if a patient has signed it but a physician has not yet signed it, are these accessible when you search? Is that how we're envisioning that, or is that how the current available repositories work, where there's an incomplete form that can be viewed by someone querying it? So like another kind of a clinician outside of that process. And the reason I asked is, if somebody has an incomplete form, that's still a really powerful tool in the event that, what the form is for sort of happens. And then you can have a much, you can actually have a conversation about, well, what did the patient want? It's written down here, and then getting a doctor's order in real time becomes possible in terms of like withdrawing resuscitative measures or moving just to comfort measures, as opposed to being like, well, we don't really have anything to go on, and this person is not able to explain what they want, and now there's nothing.
Howard, I think that's a really good point, and it's a great question. I will let you know that from almost all of the workflows I've seen in the technology in this space, and Maria will have to answer for my directives, but all the other technology workflows I've seen is that a form is not discoverable by outside sources until it has all of the required elements.
Bingo.
Okay, so that's very different from paper forms.
Well, no, not necessarily. You can't grab a half-assed portable medical form that doesn't have a doctor's signature, doesn't have any of the required fields, and surface that in the middle of a health crisis and say, here, you need to do this. There are
No.
completions.
So right. So if somebody's filled most of one out and there aren't the proper signatures, from a clinical workflow perspective, it is not a clinician's job to enforce paperwork. But if we get clues and we can pull threads and say, not in a moment of crisis, either the family or the person who has capacity has recorded some things, but it's not a order in full effect, then we can get a verbal medical order and say, hey, there's evidence here that this is what they want. They're able to communicate it in the moment, or they had paperwork that had those wishes documented beforehand. Can I act on those orders? And then I get a verbal order, yes, to step down to comfort measures or withdraw resuscitative measures altogether. That does happen. That absolutely happens.
I think that would be jurisdictional. I know RIM can speak to the state of California, but not all jurisdictions have safe harbor laws enacted. And so jurisdictionally, there is going to be reluctance on the part of the treating clinician to inform care if the document does not meet the standards that their risk management department has stated must be met.
Yeah,
I hear what you're saying from a human perspective, but I know hospitals that are like, if the T's aren't crossed and the I's aren't dotted, you deliver the standard of care, I'll fight it out with the family later. Like they're so risk averse, they're not going to honor it unless certain baseline criteria are met.
Yeah, and I think that also depends on whether or not a clinician views a situation as futile. Because, I'm not a physician, but my understanding is physicians are not required to deliver futile care. And that may be jurisdictional as well, but I would love to hear some other clinician thoughts on this.
I could see it maybe guiding, like, and I'm thinking this the way you're kind of thinking, Howard, like a paper form that was maybe half filled out but not completed, and it could maybe help guide a conversation with the medical power of attorney or the family or something like that. But I don't think it would be actionable.
Right, right. And I think that's the part I need to underline here. I'm not saying that I can pick up a half filled out form and take action. I would need a doctor's order, but as a paramedic, I can get that over the phone. And if I have well documented things and on a non-valid incomplete form because there's a missing physician signature, real time I can get a physician order. That's not the same as me taking action on a non-existent order.
I think where in the technology realm, having those discoverable though actually would do more harm than good. Because I see your point. I just think it'd be really dangerous to have incomplete forms discoverable by anyone other than the person who is having the conversation.
Understood.
Cool. I really appreciate you guys taking these individual concepts and helping us. In a digital world, there's going to be, I'll go back to my coat of many colors. There's going to be like header metadata. And the header metadata really kind of helps the receiving system file the form into the right folder in the document management system, right? And so there is a date. There is a date that goes in the header data. And that helps the system tell the human user, this is what you got. And so when I see something like, oh, well, there's an effective date, there's a date form prepared, a date form filled out, well, crud, there's a patient surrogate signature, there's a practitioner, good grief, when I've got 3 dates, which one do we float to the top? And I think, based on what I've heard, and I think everybody's all on the same page, you need to go to the practitioner signature for an order. I'm not talking about an advanced directive or anything else, but you need to see what made the order legal and actionable. That's probably the date that needs to float to the top. I think that's what you guys are telling me, but tell me to go back to sleep if I miss the point.
Maria, I'll just say that since portable medical orders are so heavily chronologically based, you do need one date to go on. And you're correct that like there are many, we have in Oregon, the date received, the date we created it, and the date it was effective. But if you're talking chronologically speaking, that form replaces the previous form on the date of signature from the healthcare practitioner.
Thanks, Abs. I think that's really important. All right, cool. That's super helpful. All right, great. That was a sticky wicket, and I knew it was going to be a tricky one, but some of this stuff we have to air with you guys, because if we don't, we're just not getting the job done. There's so much work that we can do, but if we don't get certain aspects of the metadata right, then we just missed it, the whole ball entirely. Okay, got it. Okay, it is 4 minutes before the top of the hour. Our next meeting is going to be on November 20th. By the 20th, we will have already made a decision as to whether we're going to be able to take the portable medical order additions to our implementation guide to ballot or not. We believe, because of the things that we are teasing out with you right now, because we have to file our notice of intent to ballot within the next 5 days. We believe that we are not ready to file our notice of intent to ballot. We also believe that there is a tremendous need on the part of the industry to get these things off of paper and get them to some level of sensical metadata. So we believe that we're going to not go to ballot in January, but that we are going to go to ballot in May, and that the next couple of months, because we'll have to file our notice of intent to ballot and start to freeze our IG, that the next couple of months we're going to be teasing out the hard stuff. I think we've done all the easy work, and I can't believe I'm saying that. But I think we've done all the easy stuff, and as we're putting the finishing touches on the implementation guide, we are starting to tease out all of the hard stuff that we left for the end. So I would like to invite you guys to please come back on November 20th. We are going to continue to keep pushing. We are participating in the January 2025 Connect-a-thon. We've got a lot of implementers at the table, so we're really going to be pushing. We're going to be doing the old accordion on the data, pushing and pulling and pushing and pulling. And it's really the last formalized testing event before we go to ballot. We'll keep you guys posted. We're going to stay on the every other week cadence. And if anybody needs us to respond with timing or topics or what we're doing, please know we are governed only by you. It is what you need. It is what you need to have happen. That's what sets the rules for us. So tell us how to best serve you. And I appreciate you guys coming to the table. We are so grateful for your guidance and your help. And we thank you most sincerely. If there's no walk-on topics, we're going to give you a minute or two back, and we will very, very much look forward to seeing you again on the 20th in 2 weeks.
Thank you.
Thank you, Maria.
Thank you.
Thanks, everybody.